exercise capacity. It is associated with early risks. However, in carefully chosen patients, and in Leicester, we've come up with a scoring system for volume reduction called the Glenfield BFG score, which takes into account body mass index, the FEV1, and transfer factor as three variables which help us determine the high risk from the low risk patients. So LVRS clearly shows to improve outcome, and the morbidity and mortality, which were shown in NET, is clearly lower in our present day practice. The UK average mortality is about 2 to 3% for LVRS patients done thoracoscopically. And with careful case selection, these can even be reduced. And we need randomized trials for EBV versus LVRS, was an editorial published in 2015. Fast forward a few years, we've just completed recruitment into the CELEB trial, which is a one-to-one direct comparison of unilateral VATS LVRS versus endobronchial valves. So there were 4 units which recruited: Leicester, Brompton in London, and Barts in London, and Glasgow, plus Sheffield, which had very few patients contributed. And the idea was eligible patients who had a Chartis assessment and had intact fissures were then randomized into keyhole volume reduction on one side and bronchoscopic endobronchial valve placement on the other side, with a stringent follow-up planned for acute outcomes as well as long-term outcomes, looking at quality of life, lung function, MRC score, and improvement in their CAT score and BMIs. What all of this technology allows us to offer personalized procedures for these patients. You could do a VATS LVRS, at a later date do an endobronchial valve, you could do a coil, but it should all be done in a lung volume reduction multidisciplinary team setting. So this is a patient of mine who was referred to me in 2011 with alpha-1 antitrypsin deficiency and preponderant left lower lobe emphysema. So in 2012, I did a VATS LVRS. And this was her 2 years down the line. As you all know, the lower lobe patients tend to do less well than the upper lobe preponderant patients. So she's back again with hyperexpanded lung and the diaphragm's flat. So the MDT decided to get a VQ scan, which showed that there were still targets with hypoperfusion in the left side. This is an X-ray the day before procedure, and this is the day after procedure, wherein we placed 3 endobronchial valves in the left lower lobe. So the hyperinflated lung then starts collapsing and settling down. And fast forward 3 years, she now comes back again with the same problem. On this occasion, because the disease process on the right side was more diffuse with no targets and no integral fissure, by now this patient is 79, we decided to valve the right side. So this single patient has had all 3 modalities of treatment, and this has stretched the benefit of the procedure over a period of 10 years. So VATS LVRS remains the main intervention in our practice for severe emphysema. Specialist MDT is an established practice in the UK, and it should be part of any practice offering volume reduction. Endobronchial valves are suitable alternatives, and endobronchial coils as well. And the introduction of endobronchial valves and coils and MDT have increased the number of patients benefiting from this. And the trial results, when they are analyzed and published, will guide us further in terms of how best we treat these patients. I'm going to finish off with this. This is a patient of mine.
Hello, my name's Don. I've got COPD. I started smoking when I was, mid-teens, I suppose, and carried on till I was smoking 20, 30 a day. I gave up 22 years ago. I've got emphysema. You probably know what that means. In my case, my lungs have expanded to more than twice their normal size. Somebody told me that what this means is that the air very easily gets into the bits that don't work. the parts of my lungs that did work, the elastic bits, were more resistant and the air didn't get there, which meant that I couldn't get oxygen into my blood, and that meant I couldn't get oxygen to my muscles. And so I was constantly fighting for breath, constantly tired, always struggling. To go for a walk was more or less a punishment, and I hated it. The answer, I was told, was to reduce the volume of my lungs, which didn't make any sense to me at all. Here was me struggling for breath, and you want to take some of the size of my lungs away? But indeed, lung volume reduction surgery was in fact for me the way forward. Of course, the whole idea scared me to death. I had the vision of a surgeon ripping my chest open and pulling parts of me out of it. Now, nothing of the sort. Medical science nowadays is a lot more sophisticated. They do it laparoscopically, which in normal parlance is keyhole surgery. Tiny incision. They needed to get the instruments in. They have a little camera with a light, would you believe it? And they actually stapled part of my lung. No, not with the kind of stapler that you have in your office desk, a medical device. And by this means, your surgeon will tell you more than I can, by this means they reduce the volume of my lungs. And that means that air gets to the good bits, the bits that work. Prior to that, believe me, I was an invalid. In fact, the weather we're having today was the worst possible conditions for me. Cold, damp, nothing could be more punishing than to be asked to come out and walk in this. But guess what? Now I can. It's improved my whole lung function. It's almost miraculous. 6 weeks ago at Glenfield, I got my life back. I've been walking every day since. My lungs are getting stronger. My muscles are getting stronger. I'm becoming more and more fit, and I'm enjoying it. I've even got my wife back. She's no longer my carer. She's my partner.
Thank you. Thank you. Thank you very much. So that concludes the first session of the morning. If you have any questions for the three of us, please add them onto the chat box and we can answer those. We have about 5-10 minutes for questions. There are a few already, so if I may take the first one. So there's a question which says, are there any useful addresses to train a young cardiothoracic surgeon dissecting cadavers in order to master surgical anatomy? Why not some surgical procedures and skills in Egypt and the UK? Thanks a lot for the amazing collaboration. So that question is from Lama Mohammed from Algeria. Lama, we do have a very structured curriculum in the United Kingdom for our trainees, which involves 2 courses every year, which spans over 6 years. There are 12 courses, and all these courses have anatomical dissection, wet lab using animal tissue, plasticine simulation models, cadaveric models, and the trainees are also taken to a wet lab facility in continental Europe, wherein they do all the procedures they would do in their real life in live animal models. Now, Professor Amir and I were discussing this when we were in Ismailia 2 years ago, and the plan was to replicate that as a North African, Middle Eastern hub in Ismailia. So all I'm going to say is it happens in Europe, and it hopefully will happen in Egypt and North Africa once COVID allows us to fly. So there is a plan in place, but you will just have to watch the space and we will keep you updated. So the next question is clamshell incision, does it have an application in current surgery? The short answer to your question is yes. Clamshell is a very valuable incision when it comes to emergency access, but the importance of it is doing it properly. Where people get caught out, which I'll cover in my trauma talk later in the end of the day, is they go too low. So if you go too low, you're below the pericardium, you're below the hilum, and you can't access. So although we use the submammary fold as an incision landmark, when you're in, you have to go in the 5th or the 4th interspace. And once you cross the sternum, that gives you complete access to the surgeons, the surgical anatomy of the chest. It is used in transplant. It is used in bilateral metastatectomy, but as we're all cardiothoracic surgeons, we prefer to use the sternotomy for bilateral access than clamshell. But in trauma setting, it still has utility. Any other questions? So if there are no questions, I'm going to ask my co-panelists. So if I go to Dr. Bajaj first. So she very beautifully showed us the impact of screening and how CT comes in and all those things. So when we are talking about small nodules, Amrita, one of the things which is in vogue is targeted resection or ablation using endobronchial navigation. Yeah. Endobronchial navigation to the small lesions. What is the current thoughts of the radiology fraternity in terms of ablation of these nodules, which we are going to be seeing more and more once we get the screening kicked in? You're still muted.
Sorry, apologies. I said there's no lack of enthusiasm in wanting to do it. There's no lack of expertise in wanting to do it. I think the problem is that we don't realize there'll be an avalanche. If this takes off, there's going to be an increased demand with not enough resources to deal with it. So in terms of what does the radiology fraternity think, I think they can't wait to get on with it, but I don't think we have the resources to do it.
Because I think going forwards, that'll be one area where there'll be more radiology surgical collaboration. So Barts and Hong Kong have started using endobronchial navigation to target it and then operate with a CT scanner as a hybrid procedure. So we'll have to watch the space and see how that pans out.
Very, very exciting, yes. Again, isn't it ultimately down to resources?
Any other questions for us? If not, we can break for lunch and then reconvene for the oncology session.
Since the advent of cardiac surgery 60 years ago, intraoperative myocardial protection or cardioplegia respectively has been an essential part of open heart procedures. Experimental and clinical research on this particular field is still continuing because an optimal or ideal cardioplegic solution has not been established. In the past, surgeons focused, among other criteria, on intra-ischemic myocardial energy turnover or morphology, while today safety and convenience are the main parameters for evaluation of any cardioplegic method. Regarding surgeons' convenience, it is obvious that cardioplegic reperfusions or administration of maintenance solutions are the most inconvenient and time-consuming procedures. The following remarks focus on a method to avoid such cardioplegic reperfusions without compromising patients' safety. The answer to this progress is called Custodiol. Since the advent of cardiac surgery 60 years ago, intraoperative myocardial protection or cardioplegia respectively has been an essential part of open heart procedures. Experimental and clinical research on this particular field is still continuing because an optimal or ideal cardioplegic solution has not been established. In the past, surgeons focused, among other criteria, on intra-ischemic myocardial energy turnover or morphology, while today safety and convenience are the main parameters for evaluation of any cardioplegic method. Regarding surgeons' convenience, it is obvious that cardioplegic reperfusions or administration of maintenance solutions are the most inconvenient and time-consuming procedures. The following remarks focus on a method To avoid such cardioplegic reperfusions without compromising patients' safety, the answer to this progress is called Custodiol. Custodiol is a low sodium and low calcium cardioplegic solution and the only highly buffered compound available worldwide. Significantly, the histidine buffer represents the primary osmotic ingredient of the solution. In addition to its buffering capacity, histidine is one of the most effective scavengers of free radicals known, with its mode of action comparable to mannitol. Due to its highly concentrated buffering capacity, this solution requires only a singular administration to initiate cardioplegic arrest. What are the indications to use Custodiol? At first, pediatric cardiac surgery. Also valvular surgery, followed by aortic surgery, minimally invasive surgery, redo surgery, heart transplantation. Finally, it can also be used in coronary artery surgery. In accordance with Dr. Cooley's recommendation, administration should be safe and simple, routinely using a 3/16 perfusion line and a 9 French aortic cannula. For intraoperative cardioplegia and transplantation, antegrade cardioplegic perfusion is preferred with necessarily a high-volume perfusion. Furthermore, in this situation, the extended perfusion time must be considered, as the total extracellular myocardial space requires adequate equilibration. Custodiol can be used at any patient age. However, in pediatric cases, special considerations apply. The perfusion volume must be adjusted for the infant's age, and perfusion time is shorter than in adults. Cardioplegic reperfusions appear to be harmful in neonates, as the listed references clearly demonstrate. How do we administer Custodiol? After aortic cross-clamp, it is first necessary to empty the aortic root and the left ventricle. Then, the cardioplegic perfusion is started. The solution can be administered either by roller pumps or by gravity. Electrically induced ventricular fibrillation should be avoided before cardioplegic perfusion starts, since the coordinated ventricular contractions during the initial phase of cardioplegic perfusion result in optimal equilibration. The decrease in the arteriocoronary venous PO2 difference is not affected by the mode of perfusion. The crucial reduction in the decline of the difference of arterial coronary venous oxygen partial pressure reflects reduced myocardial energy consumption, which, in turn, correlates with a corresponding increase in myocardial cell energy content. The solution's temperature should be kept between 6 and 10 degrees centigrade. Any unused portion from the initial perfusion should not be stored in a refrigerator, as rewarming will decrease the solution's pH, adding to the acidotic shift in ischemic myocardium. As already mentioned, cardioplegic reperfusions are not usually necessary. If, for some reason, cardioplegic reperfusion is necessary, perfusion time should be limited to 1 to 2 minutes, equivalent to 200 to 400 ml. Time lapse is the primary drawback of any replegia. It is evident that replegia is well known to be harmful to the neonatal heart. In case of initial retrograde administration and of retrograde replegia, consider the physiological fact that only 70% of the coronary venous blood drains into the coronary sinus. Consequently, right heart failure constitutes the main risk of retrograde administration. One additional concern relates to blood pH after systemic custodial administration. The pH of this buffer-containing solution is temperature dependent. At 34 degrees centigrade, the solution's pH is 6.9. We can predict the blood pH following systemic custodial administration and thereby calculate the pH shift towards acidosis that is solely attributable to physicochemical effects. How to manage custodial perfusion in patients with severe aortic insufficiency. Try to perfuse antegradely first. If the heart does not stop within 3 minutes, open the aortic root and continue with isolated left coronary perfusion. In most cases, the heart will stop with this approach. If it does not, interrupt the left-sided perfusion and perfuse only the right coronary artery for 1 to 2 minutes, and then continue the left-sided perfusion. If retrograde perfusion is preferred, perfusion pressure should be only 20 to 30 millimeters of mercury. Systemic administration leads to hemodilution, which can be prevented by a hemofilter. It has been suggested that systemic custodial administration leads to neurological seizures in neonates due to systemic hyponatremia. However, this is not the case. Studies from Norway and Italy demonstrated that an apparent hyponatremia based solely on measured laboratory serum concentrations is not causally related to seizure activity in this situation because it is isotonic. To prevent such hyponatremia, administration of 200 to 300 millimole sodium to the body's circulation is recommended. Obviously, sodium chloride must not be added directly to the cardioplegic solution because this would seriously interfere with its effectiveness. Our recent retrospective as well as prospective studies on systemic sodium content and osmolality clearly support the validity of our aforementioned protocol.
morning. I'm Rajesh Shah. I'm a thoracic and transplant surgeon in Manchester. I'm also the president-elect of SCTS. I just want to thank the Egyptian Society and also, of course, the SCTS for inviting me to give this presentation, and it's a great pleasure to be part of this course, really. I'm going to be talking about surgery for lung cancer. Now, I'm going to present 5 groupings in lung cancer to discuss the workup, the staging, and the management. The reason for grouping them in different subsets is to try and standardize the workup, the assessment process, the staging process, so as to achieve consistency in the decision-making process and thereby the outcomes in the management of lung cancer. Now, I work in Manchester. We serve a population of 3.2 million. We do about 630 lung cancer resections in a year. And so for us, it is quite important to have a degree of standardization in the staging, diagnosis, and the assessment process in the management of lung cancer. So group 1 is a peripheral tumor with normal hilar and mediastinum with no evidence of distant metastases. So these are usually obviously stage 1 tumors, and it also includes tumors with a pulmonary solid component within the GG of 5 millimeters or more. So early stage lung cancers, consider doing a CT scan, consider doing a PET CT, consider doing a CT guided biopsy if possible, or to do a radial EBUS bronchoscopy to achieve a diagnosis. All these patients will have standard workup in terms of spirometry, including transfer factor. We introduce shuttle walk test early in our assessment process and routine cardiological examination. Echocardiogram is done in only very specific cases as outlined below. Once the CT PET and the appropriate workup is done, they're all discussed within the MDT. The second group is tumors, central tumors with evidence of N1 lymphadenopathy with normal mediastinum on staging CT with no distant metastases. Now, it's important to recognize that in this group of patients, the PET CT has a 15% false positive rate and about 25% false negative rate for N2 to N3 disease. And hence, in addition to CT PET, staging EBUS is considered, and this is the staging EBUS and all appropriate lymph nodes to rule out N2, N3 disease needs to be considered. Now, once all these tests are done, again, they're all discussed within the MDT. And in Manchester, we have a standard prehabilitation protocol, which includes a smoking cessation, an exercise program, and addressing the nutritional requirements as part of any patient who is undergoing radical treatment for lung cancer. Group 3 is patients with primary tumor and discrete mediastinal lymphadenopathy with no distant metastases. Again, it's important to recognize that the false positive rate of 15% with CT PET and a false negative rate of 25% for N2, N3 disease, and hence following CT PET, staging EBUS is considered, and in addition to that, a contrast enhanced brain imaging, either CT or MRI, is considered. This physiological workup is standard as in the other 2 groups. And once this workup is done, these patients are discussed within the MDT. And again, once again, they all follow a common prehabilitation and optimization protocol following assessment by the chest physicians. Group 4 is the conglomerate and invasive nodal malignancy on staging CT. These are unlikely to be candidates for surgery, and the idea is just to get tissue diagnosis. So following CT PET, an EBUS and an EBUS guided biopsy is considered to get adequate tissue for further oncological management. Group 5 is patients with distant metastases on staging CT. And again, in this group of patients, the primary issue is to get a histological diagnosis, followed by appropriate molecular staging for consideration of oncological management. In majority of the cases, there are some cases with oligometastatic disease which can be considered for surgery, and we'll be discussing that later on. The primary reason, as I said, to group them into separate groups is to standardize the preoperative workup, staging, and assessment process. And the reason is that this part of the process greatly influences the resection rates and as we know, the resection rate varies in different parts of the country and between different countries, and the preoperative assessment staging plays a major role in these differential resection rates. I'm sure this has been touched upon before, but just to mention it, there are 3 components when we carry out risk assessment for surgery. Number 1 is to estimate the perioperative mortality, which is done using a thoracoscore. As we know, thoracoscore is currently recommended, though is not very good and has got some limitations. The second component is to assess the risk of the postoperative cardiac event, which is mainly done using American Heart Association guidelines. And the third risk assessment component is to estimate the postoperative dyspnea, which is done using estimation of the postoperative predicted transfer factor and spirometric assessment. This is the revised cardiac risk index. As we know, the more the number of factors, the higher is the risk of major cardiac complications. And the various risk factors are as stated in the slide, which includes any form of thoracic surgery, ischemic heart disease, congestive cardiac failure, cerebrovascular disease, insulin-dependent diabetes, and preoperative serum creatinine level of greater than 177. When you have more than 3 cardiac risk factors, it is recommended that a cardiological assessment takes place. This is variable. We don't necessarily do it in our department, but this is what the recommendations are. The risk assessment for postoperative dyspnea is by using spirometry and transfer factors, studies in all patients, and stratify them into 2 groups. When the predicted postoperative FEV1 is greater than 40% and the transfer factor is greater than 40%, the risk of postoperative dyspnea is low, and these patients can undergo surgery without any issues. When the predicted postoperative FEV1 or the predicted postoperative transfer factor is less than 40%, it is recommended they have further functional assessment, either in the form of shuttle test or stair climbing or CPEX, thereby facilitating them into stratifying them into the moderate risk or the high risk group, and thereby facilitating consent and decision-making process within this group of patients. As I said, in our center, we introduced the functional assessment much more earlier, and that is primarily because we serve 10 or 12 different hospitals, and we have noticed that there is variation in the lung function assessment in different centers. The postoperative pathway is, again, there is a lot of variation in different departments, but in general, there are 3 pathways for for following surgery for these group of patients. One is the uncomplicated group of patients or low-risk patients, which can go straight to thoracic surgical ward with some form of monitoring. There are patients who are intermediate to high risk, and some of these factors are highlighted in this slide. Especially patients with borderline lung functions, renal dysfunction, or cardiac compromise. They need HDU level care. And of course, there are some highly complex patients who might need level 3 care. Now, we all know staging influences survival. Staging also influences how we stratify them and select different modalities of treatment. This is the 7th edition, which originally was utilized in 2007, 2008. Currently, everywhere in the world, I think the 8th edition is being utilized, and we will touch upon it later on. This is the 8th edition of lung cancer staging, which is now